Aparajita Banerjee.
So good morning, everybody. Today my talk will be on clinical outcome of strabismus surgery in few cases of acute acquired concomitant esotropia. Acute acquired concomitant esotropia is a very rare type of esotropia characterized by sudden onset of concomitant esotropia along with diplopia. Now features that...
Can you please speak in a little closer to the mic?
Common features which I found in all my cases medium to large angle concomitant esotropia of acute onset, all were non-accommodative in nature, all were associated with diplopia and presented at age greater than 5 years, and in all my cases there was no tendency for spontaneous resolution even after 1 to 2 months of follow-up. This was a retrospective study carried out at the ophthalmology department of SCB Medical College and Hospital, and the medical records of all the patients diagnosed with AACE were reviewed from the time period January 23 to September 23. Now, inclusion criteria, all the cases of concomitant esotropia with acute onset along with diplopia and with visual acuity, best corrected visual acuity more than 6/9 in each eye were included. Exclusion criteria, non-concomitant esotropia, accommodative concomitant esotropia, amblyopia, patients with past history of ocular surgery and BCVA of less than 6/9 in either eye were excluded. Complete medical history, ophthalmological evaluation, orthotic evaluation were performed on all the patients. Age at onset of onset of squint was verified from the patient's history as well as from the photographs from the patients. The angle of deviation was measured in all the cardinal points along with primary gaze after full refraction by PBCT, both for distance and near. Stereopsis was measured, and all the cases were sent for neurological consultation, and NCCT, brain and orbit was done for all the cases. In all my cases, I could find out there was no history of strabismus and no neurological disorder was found. But surprisingly, we had 5 patients in my series, and 4 out of them had increased use of smartphone use and increased digital screen time use in the last 6 months. Now, these are my first case scenario of 40 prism diopters esotropia. These are the other cases. Case 2, 40 prism diopters esotropia. Case 3, 35 prism diopters esotropia. Case 4, 50 prism diopters esotropia. And case 5, 40 prism diopters esotropia. Age distribution, one patient was less than 15 years of age. Others were all more than 15 years of age. And one patient was female. Apart from that, all were male. Etiological factor, as I already told, 4 cases were found to be associated with increased use of smartphone use, and 1 cases could be associated with increased frequency of driving in the last 6 months. So, according to the case-wise type of surgery for case 1 and case 5, we went for bilateral medial rectus recession. All the other 3 cases were selected for unilateral medial rectus recession along with lateral rectus resection. And post-operatively, we could see all the patients were orthotropic, and till now, the follow-up. So to conclude, I'll tell the increased smartphone use will be an important and etiological factor for the acute onset of AACE syndrome or the recent surge in AACE syndrome in nowadays. And strabismus surgery serves as a very useful method to treat large angle acute acquired concomitant esotropia. And in few of the cases which we have operated, we find there was no significant difference between bilateral medial rectus recession and unilateral medial rectus recession along with lateral rectus resection. Thank you.
So all your patients were diplopia free following surgery?
Pardon, ma'am?
All your patients were diplopia free following surgery?
Yes, ma'am. They were diplopia free.
And what was your refraction?
Sir, 2 of my patients were -1 and -1.5 diopter myopic. Rest were...
I'm asking about the retinoscopy of, and what was the mode of refraction for esotropia particularly?
So I had atropinized and then full cycloplegic refraction on all the patients.
Okay.
But no significant refractive error was there, so we didn't prescribe any glasses.
So this association, like you're trying to hypothesize that smartphone or like prolonged near vision focusing
yes,
is induced, the esotropia is not connecting well.
In few of the case
And what was the age, mean age?
one case was less than 15, like she was 12-year-old girl, and rest or from 20 to 25.
Okay.
One was 45, I think. One was a very old patient. One was 45.
No, 35.
No, can you show?
35. One was 35. One she said 35.
Okay.
Anyway, so you said smartphone use is an important risk factor for.
I said, sir, it could be. Means future studies, my case are very limited.
No, did you try
future-
to find any association statistics to derive this conclusion?
Sir, in few of the recent case reports, increased use of near activities and convergence have led to the AAC syndrome, Francis-City syndrome.
No, but then
iota.
what I mean is statistically it should be significant
Yes, sir.
to
Yes, sir.
derive this
But
conclusion.
one of my demerit is I have very few
this one.
cases.
So you have done stereopsis examination preoperatively. So what did you find in that?
Sir, it was reduced.
And how many had diplopia?
All the patients had diplopia, sir. That's why they were operated.
So diplopia and stereopsis.
So asking very pertinent questions for this case study. Basically, rather than symptomatic like diplopia, measuring the diplopia, you should have measure all like what is your refraction and what is your accommodative convergence and all. And stereopsis is also a very important part.
Yes, sir.
So that should be, you have only 6, 7, how many cases?
I have only 5 patients.
5 cases, so that can be easily tabulated for the stereopsis,
sir.
all that.
I'll keep in
And
mind, sir.
stereopsis is a very important part of.
Yes, sir.
And again, using this smartphone and all this, leaking the CD body spasm or something like that, and also maybe something, unless you're not connecting well.
So, Jasprit asked one question about stereopsis. So, how can a diplopia patient have stereopsis? That is a basic, very basic.
No,
thing.
they will not have stereopsis.
So, you don't. That's what you should have answered.
Yes.
And so if they have diplopia, why do you want to measure the stereopsis?
Yes, sir.
So you don't need to do all these things in all these patients. And why did you do bilateral in some and unilateral in?
Sir, those cases in which I have done bilaterally, the esotropia was alternating. It was not fixed to one eye. And in cases which was where predominantly it was fixed, I opted for unilateral.